Welcome to today's session on human immunodeficiency virus. A 27-year-old man comes to the clinic complaining of fever, headache, sore throat, and malaise that has persisted for over a week. He also developed a rash 2 days ago. When we take a detailed history, he admits to having unprotected sexual intercourse with sex workers during his business trips. His last sexual encounter was 3 weeks ago. He denies any history of blood transfusion or intravenous drug use. This clinical presentation is highly suggestive of acute HIV infection, also known as acute retroviral syndrome. The timing is crucial here. Symptoms appearing 3 weeks after potential exposure falls within the typical window period for acute HIV infection, which usually occurs 2 to 4 weeks post-exposure. The constellation of symptoms, fever, malaise, sore throat, and rash, are classic features of the acute phase of HIV infection. This represents the body's initial immune response to the virus. The patient's risk factors, particularly unprotected sexual contact, significantly increase the likelihood of HIV transmission. As we progress through this lecture, keep this case in mind. HIV is a spherical virion with a distinctive cylindrical core. The genome consists of single-stranded RNA that is linear and diploid, meaning the virus carries 2 copies of its RNA genome. The envelope proteins are particularly important. They undergo antigenic variation, which means they constantly change their structure. This is one reason why developing a vaccine against HIV has been so challenging. The virus essentially keeps changing its appearance to evade the immune system. Inside the virion, we find the reverse transcriptase enzyme. This is absolutely crucial to HIV's life cycle. Unlike most viruses that use DNA as their genetic material, HIV uses RNA. The reverse transcriptase converts this viral RNA into DNA once inside the host cell. Hence the name reverse transcriptase, as it reverses the normal flow of genetic information. Another critical enzyme is the protease, which is required for producing infectious virus particles. This enzyme has become an important drug target in HIV treatment. The virus has an envelope derived from the host cell membrane, studded with glycoproteins GP120 and GP41. These envelope proteins are essential for the virus to attach to and enter target cells. During replication, the reverse transcriptase makes a DNA copy from the genomic RNA. This DNA, called provirus DNA, integrates into the host cell's chromosome and serves as a template for producing new viral RNA. An important characteristic of HIV is its high genetic variability. The virus mutates frequently during replication, which contributes to drug resistance and immune evasion. In the interior of the virus, you can see 2 molecules of viral RNA shown in red, associated with the reverse transcriptase enzyme shown in purple. Remember, HIV is unique in carrying 2 copies of its RNA genome. This diploid nature provides genetic redundancy and contributes to the virus's ability to develop mutations and drug resistance. Surrounding the RNA and reverse transcriptase is the rectangular nucleocapsid, composed of P24 proteins shown in yellow. The P24 protein is clinically significant because we can detect it in blood tests. It serves as an early marker of HIV infection, often detectable before antibodies appear. Note that the diagram mentions that viral protease and integrase are also located within the nucleocapsid, though they're not shown due to space limitations. On the exterior, we see the lipid bilayer envelope, which the virus steals from the host cell membrane when it buds out. Embedded in this envelope are the 2 crucial envelope proteins, GP120 and GP41, shown in green. The GP120 protein is responsible for binding to the CD4 receptor on target cells, while GP41 facilitates the fusion of the viral envelope with the host cell membrane. This structure is not just academic. Understanding it helps us comprehend how antiretroviral drugs work. For example, protease inhibitors target the viral protease, reverse transcriptase inhibitors block the RT enzyme, and fusion inhibitors prevent GP41 from mediating viral entry. Entry inhibitors can block the GP12-CD4 interaction. The lipid envelope also makes HIV relatively fragile outside the body. It's easily destroyed by soap, detergent, and common disinfectants. This is why HIV is not transmitted through casual contact or environmental surfaces. First, HIV specifically infects cells of the immune system. This is a cruel irony. The virus targets the very system designed to protect us from infections. HIV's primary target is the CD4-positive T lymphocyte, also known as T helper cells. These cells are crucial coordinators of the immune response. HIV also infects macrophages and dendritic cells. By destroying CD4 cells, HIV progressively dismantles the immune system, leaving patients vulnerable to opportunistic infections and certain cancers. Second, the provirus remains permanently associated with infected cells. After HIV's reverse transcriptase converts viral RNA to DNA, This viral DNA integrates into the host cell's chromosome. Once integrated, the proviral DNA becomes a permanent part of the cell's genome. This means that as long as the infected cell survives, it carries the potential to produce new virus particles. This is why we cannot cure HIV with current treatments. Even when antiretroviral therapy suppresses viral replication to undetectable levels, the integrated provirus remains dormant in long-lived cells, ready to reactivate if treatment stops. Third, HIV causes a slowly progressive, chronic disease. Unlike acute infections that resolve quickly, HIV infection, if untreated, progresses over years to decades. This slow progression occurs because the immune system initially compensates for CD4 cell destruction by producing new cells. Eventually, however, the virus overwhelms this compensatory mechanism, leading to AIDS. Let's start with the known routes of transmission. The first major category is inoculation through blood. This includes transfusion of contaminated blood and blood products, though this is now extremely rare in countries with proper screening programs. Needle sharing among intravenous drug users remains a significant transmission route. Healthcare workers face risk through needle stick injuries, exposure through open wounds, or mucous membrane contact with infected blood. Even tattoo needles can transmit HIV if not properly sterilized. The second major route is sexual transmission. Both anal and vaginal intercourse can transmit HIV. Anal intercourse carries the highest risk due to the fragility of rectal mucosa. Vaginal intercourse also poses significant risk. The virus is present in semen, vaginal fluids, and blood. Any sexual activity that involves exchange of these bodily fluids can potentially transmit HIV. The third route is perinatal transmission, from mother to child. This can occur through three mechanisms: intrauterine transmission during pregnancy, peripartum transmission during delivery when the infant is exposed to maternal blood and fluids, and through breast milk during breastfeeding. Without intervention, the risk of mother-to-child transmission is about 25 to 30%. However, with proper antiretroviral treatment during pregnancy, delivery, and to the newborn, this risk can be reduced to less than 1%. Now, equally important is understanding routes not involved in transmission. HIV is not transmitted through close personal contact with household members. You cannot get HIV from hugging, kissing on the cheek, sharing utensils, or living in the same house with an HIV-positive person. Healthcare workers who are not exposed to blood are not at risk from routine patient care activities. HIV is not transmitted through saliva, tears, sweat, or casual contact. The graph shows three key parameters: the viral load in red, CD4 T-cell count in blue, and the progression through different stages of infection along the bottom. Let's walk through this timeline from left to right. Immediately after exposure, during the first few weeks, we see the acute HIV syndrome. This corresponds to our case patient's presentation. During this phase, viral load skyrockets as the virus replicates rapidly throughout the body. You'll notice the viral load reaches very high levels, often exceeding 1 million copies per milliliter. This is why acutely infected individuals are highly infectious during this period. The CD4 count drops sharply during acute infection as the virus destroys these cells. Following the acute phase, the immune system mounts a response, and viral load decreases substantially. We enter what's called the clinical latency period, or chronic asymptomatic infection. Don't let the term latency fool you. The virus is still actively replicating during this phase, just at lower levels. This period can last from several years to over a decade. During this time, patients typically feel well and may not know they're infected if never tested. However, viral replication continues in lymphoid tissue, and CD4 cells are slowly but progressively destroyed. Notice that throughout the latency period, the CD4 count gradually declines, while viral load remains relatively stable but detectable. The immune system is fighting a losing battle. It's replacing CD4 cells but not fast enough to keep pace with viral destruction. Eventually, we reach a critical point where the CD4 count falls below 200 cells per microliter. At this stage, the patient progresses to AIDS, acquired immunodeficiency syndrome. The viral load increases again as the damaged immune system can no longer control viral replication. Opportunistic infections appear, shown at the bottom of the graph. The infection begins when HIV enters the body through one of the transmission routes we discussed. The virus first infects macrophages in the genital tract or at other sites of entry. Macrophages are important because they're relatively resistant to the cytopathic effects of HIV, meaning they can harbor the virus without being destroyed immediately. These infected macrophages serve as a Trojan horse, carrying the virus throughout the body. From the initial site of infection, HIV disseminates via the bloodstream and localizes in dendritic cells throughout lymphoid tissue. Dendritic cells are antigen-presenting cells found in lymph nodes and other lymphoid organs. These cells normally help coordinate immune responses, but HIV exploits them as vehicles for further spread. HIV then infects CD4-positive lymphocytes as they move through the germinal centers in lymph nodes. The germinal centers are areas where immune responses are generated, so they're rich in CD4 cells, exactly what HIV needs. This creates a reservoir of chronically HIV-infected cells within lymphatic tissue throughout the body. These reservoirs are critical because they persist even during treatment and represent a major barrier to curing HIV. During the acute phase, we see very high-level viral replication in CD4 cells, corresponding to the viral load spike we saw in the natural history graph. This massive viral replication causes the mild flu-like illness our case patient experienced: fever, malaise, sore throat, and rash. The lymph nodes become infected and serve as sites of virus persistence during the asymptomatic period. Even when patients feel completely well, the virus continues replicating in these lymphoid tissues. This ongoing replication in the lymph nodes explains why the infection never truly goes away without treatment. Following the acute phase, the patient enters a latent period that is clinically asymptomatic. This means the patient feels completely normal and healthy. This period can last from several months to many years, typically averaging about 8 to 10 years without treatment, though there's significant individual variation. Some patients, called rapid progressors, may develop AIDS within 2 to 3 years, while others, called long-term non-progressors, may remain asymptomatic for 15 years or more. During this asymptomatic period, a critical balance is maintained. On one side, we have the death of infected CD4 lymphocytes due to viral replication and direct viral cytopathic effects. On the other side, we have the production and replacement of new CD4 cells by the bone marrow and thymus. As long as this balance holds, the CD4 count remains relatively stable and the patient remains clinically well. However, it's crucial to understand that this balance is not sustainable indefinitely. The virus continues to replicate in lymphoid tissue throughout this period. Each day, billions of viral particles are produced and billions of CD4 cells are destroyed. The immune system works hard to replace these cells, but it's fighting a losing battle. Think of it like trying to fill a bathtub while the drain is open. Initially, if the water flows in fast enough, you can maintain the water level. But if the drain keeps getting wider, which is what happens as HIV infection progresses, eventually, you can't keep up, and the water level drops. This is why we say the latent period is virologically active. The virus is never truly dormant during this phase. Understanding this concept explains why starting antiretroviral therapy during this asymptomatic period is beneficial. We can stop the ongoing damage before the immune system is irreversibly compromised. The progression to AIDS is characterized by a rapid decline in CD4-positive cell count. Remember the balance we discussed in the latent period? Eventually, that balance tips decisively in favor of viral destruction. The immune system can no longer produce enough new CD4 cells to replace those being destroyed. The CD4 count drops precipitously. The critical threshold is when the CD4 count falls below 200 cells per microliter. To give you context, a healthy person typically has a CD4 count between 500 and 1500 cells per microliter. When it drops below 200, we define this as AIDS, regardless of whether opportunistic infections are present. As the CD4 count declines, we see the appearance of increasingly frequent and serious diseases and opportunistic infections. These are called AIDS-defining illnesses. Opportunistic infections are caused by organisms that don't typically cause disease in people with normal immune systems. When your CD4 count is very low, these organisms take advantage of the weakened immunity. Hence the term opportunistic. The loss of immune capacity is not just quantitative but also qualitative. It's not just about having fewer CD4 cells. The remaining cells don't function properly either. This leads to susceptibility to a wide range of infections: bacterial, viral, fungal, and parasitic, as well as certain malignancies like Kaposi's sarcoma and non-Hodgkin lymphoma. Without treatment, once a patient reaches the AIDS stage, survival is typically measured in months to a few years. However, it's crucial to emphasize that with modern antiretroviral therapy, progression to AIDS can be prevented entirely. Even patients who have developed AIDS can have their immune system substantially restored with treatment. Their CD4 counts can increase, opportunistic infections can be prevented, and life expectancy can approach that of the general population. In the first few weeks, there's a dramatic spike in viral RNA copies, shown by the red line. During acute infection, the patient may experience acute retroviral syndrome, the flu-like symptoms our case patient presented with. Simultaneously, we see a sharp drop in the CD4 count, shown by the blue line. The virus is destroying CD4 cells faster than they can be replaced during this initial assault. In this acute stage, opportunistic infections even at this early stage. Following the acute phase, the immune system mounts a response. You can see the viral load decreases substantially, and the CD4 count partially recovers. We enter the clinical latency period, marked on the graph as, quote, clinically silent, HIV infection. This period is represented by the long, relatively flat portion of the graph. Notice that it can extend for many years. The x-axis shows this period lasting up to 10 years or more. During this latency period, patients are asymptomatic. They feel completely healthy. However, look carefully at what's happening to the CD4 count during this time. It's gradually, steadily declining. Meanwhile, the viral load remains detectable and relatively stable. This illustrates the ongoing viral replication and immune destruction we discussed earlier. As we move toward the right side of the graph, we see the CD4 count approaching and then crossing the critical threshold of 200 cells per microliter, marked by the horizontal dotted line. At this point, we enter the AIDS phase, labeled as opportunistic diseases on the graph. Notice what happens to the viral load during the AIDS phase. It begins to increase again. This occurs because the damaged immune system can no longer control viral replication effectively. The patient becomes vulnerable to the opportunistic infections and malignancies that define AIDS. The graph also shows antibody development, indicated by the window at the top. You can see that antibodies to HIV don't appear immediately after infection. There's a window period of several weeks where the virus is present and can be transmitted, but antibodies are not yet detectable. This is why we use tests that detect viral RNA or P24 antigen for early diagnosis. This time course represents untreated infection. With antiretroviral therapy, we can flatten the viral load to undetectable levels and allow the CD4 count to recover and stabilize, preventing progression to AIDS entirely. The diagram is organized vertically by CD4 count, with higher counts at the top and lower counts at the bottom. Let's work our way down from top to bottom, as this mirrors how HIV disease progresses. At CD4 counts above 500 cells per microliter, which is near normal immunity, patients with HIV are generally asymptomatic and don't typically develop opportunistic infections. They may experience some common infections, like candidal vaginitis or bacterial infections, but nothing unusual. As the CD4 count drops below 500 and approaches 200 cells per microliter, we begin to see certain infections emerge. Tuberculosis can occur at any CD4 count, but becomes more common as immunity declines. Bacterial pneumonia, herpes zoster, and oral or vaginal candidiasis may appear. Kaposi's sarcoma can also develop during this range. When the CD4 count falls below 200 cells per microliter, the threshold for AIDS diagnosis, we see the emergence of more serious opportunistic infections. Pneumocystis jirovecii pneumonia, often abbreviated as PCP, becomes a major concern. This was once the leading cause of death in AIDS patients before effective prophylaxis became available. Patients also become vulnerable to cryptococcal meningitis, toxoplasma encephalitis, and progressive multifocal leukoencephalopathy. As the CD4 count drops even further, below 100 cells per microliter, additional opportunistic infections appear. Cryptosporidium can cause severe, chronic diarrhea. Microsporidiosis can affect multiple organ systems. Candidiasis can progress from oral thrush to esophageal involvement, causing painful swallowing. At very low CD4 counts, particularly below 50 cells per microliter, we see the most severe opportunistic infections. Cytomegalovirus can cause retinitis, leading to blindness, colitis, and encephalitis. Mycobacterium avium complex, or MAC, causes disseminated infection with fever, weight loss, and anemia. The primary screening method is serology. The most commonly used initial screening test is ELISA. This fourth-generation test detects both HIV antibodies and the P24 antigen. The advantage of this combined test is that it can detect infection earlier than antibody-only tests, because P24 antigen appears before antibodies develop. Other screening options include latex agglutination and ELISA tests performed on serum. We also have rapid oral antibody tests that use saliva samples, providing results in about 20 minutes. These are particularly useful in settings where immediate results are needed, such as labor and delivery units or emergency departments. Urine antibody tests are also available and offer non-invasive screening options. When a screening test is positive, we need confirmation. This is where immunofluorescence assays or line immunoassays come in. The Western blot analysis was traditionally used as the gold standard confirmation test, but newer algorithms are moving toward using a second different antibody test for confirmation, followed by an RNA test if results are discordant. For detecting virus directly in blood, we use virion RNA reverse transcriptase PCR, also called nucleic acid amplification testing or NAAT. This test is performed on plasma and can detect HIV RNA even before antibodies appear. This is crucial for diagnosing acute infection, like in our case patient. Real-time RT-PCR is used for quantitation, measuring the viral load in blood. This is essential for monitoring treatment effectiveness. The P24 antigen test serves as an early marker of infection. It can be positive before antibodies develop, during that window period we discussed. However, P24 levels drop once antibodies appear, so it's mainly useful for early detection. Viral culture and isolation from mononuclear cells in blood is possible, but not readily available in most clinical laboratories. It's primarily a research tool rather than a routine diagnostic test. Finally, we monitor CD4 T-cell counts and the CD4 to CD8 T-cell ratio as indicators of HIV disease progression. These tests don't diagnose HIV infection, but tell us about the state of the immune system in known HIV-positive patients. Information about safe sex practices and awareness about transmission routes. Education must be culturally appropriate, scientifically accurate, and accessible to all populations, especially those at higher risk. Understanding how HIV is and isn't transmitted helps people make informed decisions about their behavior and reduces stigma. Screening of blood products, and organs is critical. In countries with robust screening programs, transfusion-associated HIV transmission has become extremely rare. All donated blood is tested for HIV using highly sensitive tests. Similarly, organs and tissues for transplantation are screened. This has virtually eliminated HIV transmission through the medical system in developed countries. Infection control practices, particularly universal or standard precautions, protect healthcare workers and patients. Universal precautions mean treating all blood and body fluids as potentially infectious, regardless of the known infection status of the patient. This includes using gloves when handling blood or body fluids, proper disposal of sharps in puncture-resistant containers, and appropriate use of personal protective equipment. These measures protect healthcare workers from occupational HIV exposure. Additional prevention strategies worth mentioning include pre-exposure prophylaxis or PrEP, where people at high risk take antiretroviral medications to prevent infection. Post-exposure prophylaxis or PEEP, which involves taking antiretroviral drugs after potential exposure. Prevention of mother-to-child transmission through treating pregnant women with HIV. Harm reduction programs including needle exchange for people who inject drugs. And promotion of male circumcision, which reduces the risk of HIV acquisition in heterosexual men. Unfortunately, despite decades of research, we still don't have an effective vaccine against HIV. The virus's high mutation rate and ability to integrate into host cells make vaccine development extremely challenging. Multiple vaccine candidates have been tested in clinical trials, but none have proven sufficiently effective for widespread use.